Good afternoon, everyone. We're going to get started with today's Romano rounds. I'm Dr. Rob Weissman, professor of psychiatry, and I'm chief of clinical services in the community division. Today's grand rounds is both in person as well as via Zoom. We have a number of members who are online, and just to refresh those who are online, please make sure that you enter any questions in the chat or thoughts, and we'll address those around quarter to the hour. We'll be punctual with our time today. We'll go until approximately 1 o'clock and then make sure everyone has time to move on. Before I start, I just wanted to thank a few people, Steve Fasone and his crew, who set this up all the time and make it easy for us to communicate our grand rounds. We have our interpreters, so thank you all for showing, and for the presenters today, who I'll introduce in a moment. But this grand rounds is named after Dr. John Romano, who I unfortunately did not have the pleasure to meet. I came a year after he departed, but I think we couldn't have a more appropriate or applicable group presenting today in the spirit of Dr. Romano. His really philosophy was the biopsychosocial model with George Engel, but even more to serve individuals who are underserved in our community. And nothing speaks of that as well as strong recovery and the history and future of that. The title today of our rounds is 50 Years of Strong Recovery, Making History and Embracing the Future. We have two very esteemed guests today presenting, and a lot of people in the audience who make Strong Ties what it is, strong recovery, that is. Subtle slip of the tongue there, huh? But we're going to start out with Dr. Gloria J. Baciewicz. Dr. Baciewicz is professor of clinical psychiatry. She has a very long CV. I'm not going to waste her time today talking about it, other than there's probably no one in this community, this state, or this nation that's more qualified to be talking today about addiction, the history, and the future. Following Dr. Baciewicz's presentation, Dr. Myra Mathis, who is currently assistant professor of psychiatry and also medical director of Strong Ties and part of our community division leadership team. Looking very much forward to this, and not to belabor any further, I would like to introduce Dr. Gloria Baciewicz.
Thank you, Rob. Okay. I think we already went through the disclosures. We have nothing to disclose. These are our topics: 50 years of strong recovery, including some local history to provide the setting for our history after that, and then innovative and integrative approaches to education, clinical care, and research. So I'll do the 50 years of strong recovery, and Dr. Mathis will do the future, innovative and integrative approaches. And that is certainly fitting, because I retired and stepped down as medical director last year, and Dr. Mathis is our new medical director. For if anybody doesn't know that, she's also the program director for our Addiction Psychiatry Fellowship, which was just approved. So I was going to say that I get the fun part, which is the history, but I think Dr. Mathis has a fun part too, because you can speculate a lot about what the future will be like. It's a field that has a lot to offer, and we've lived through a lot of that, certainly since the 80s. When you look at historical resources for history of addiction treatment, one of the most important ones is the works of William White. He's very prolific. He wrote Slaying the Dragon, the history of addiction treatment and recovery in America. And he also wrote the chapter on history in the Principles of Addiction Medicine book. And he has, if you ever want to look up any topic in American history for addiction treatment, you can look at the William White papers at the link that's mentioned there on this slide. So to start at the very beginning in our region, we can talk about Native American approaches to alcohol use disorder. Native American healers used botanical agents to suppress alcohol craving, produce aversion, or facilitate personal transformation. And these were called sobriety circles. The sheet there is a list of chronology of founding dates of addiction recovery mutual aid groups, and the sobriety circles began in the mid-1700s. The local connection here is the Code of Handsome Lake. This was a sort of ethical code that Handsome Lake wrote. Handsome Lake was a person, it's not referring to a lake or a place, but the place where Handsome Lake resided was Seneca. So he was a Seneca and contributed a lot to Native American views of sobriety circles and so forth. Dr. Benjamin Rush, we can sort of claim him because he was nearby in Philadelphia. He is known as the father of American psychiatry. I don't know what we'd call him today, maybe the parent or the pioneer of addiction. I'm sorry, psychiatry in general. And he's on our, a lot of our psychiatry, APA literature and website and so forth. In 1784, he wrote the first American treatise on alcohol use disorder. So this was entitled Inquiry into the Effect of Ardent Spirits on the Human Body and Mind. And ardent spirits were basically hard liquor. So in this scale that he wrote, this is called the Moral and Physical Thermometer that Benjamin Rush wrote. And I think it shows up pretty well on the slide there. He described temperance as drinking water and milk, but also beer and wine, and excess as drinking hard liquor. So, he didn't have total abstinence in mind, and a lot of the early temperance advocates did not have total abstinence in mind either. So the other interesting local place is the New York State Inebriate Asylum. This is later, this began in 1864. It's in Binghamton, New York. And it was the first hospital in the US which was actually purpose-built for treatment of alcohol use disorder as a medical condition. Later on, this became Binghamton State Hospital. It's on the National Register of Historic Places. And if you look closely, you could see a chain link fence around it nowadays because basically they haven't decided what to do with it. A lot of groups want to preserve it in some way. The last thing I read about it that was available on the internet was dated 2019, that the OMH owns it, but the university, Binghamton University, manages it. And that was in 2019, so I suspect this got delayed because of COVID, and maybe we'll hear something about that in the future. But this was an exciting development, and actually a little bit later, in the 1870s, there developed a American Association for the Treatment of Inebriety. And, often we think that there was no joy in treatment back in the 1800s, and they didn't have very many options. But if you were to suddenly transport yourself into the late 1800s, you would find a lot of very excited medical professionals, and these folks would be excited about their new association and their inebriate asylum, and there were others in other states as well, and also they had a journal of inebriety. So there was a lot of hopefulness, and alcohol use disorder was seen as a medical disorder. So what happened in our specific Finger Lakes area? Well, there were a lot of well-known figures in our area who had opinions about temperance and prohibition. And you may be surprised to find out that Frederick Douglass, our local fellow, was in support of temperance movements. Now, temperance movements at that time were kind of what Dr. Benjamin Rush thought, that they were not necessarily forbidding maybe beer or wine that people had with dinner or something like that, but what they were attacking is the liquor traffic itself as a primary target. And this was seen as a form of predatory capitalism. The other person we can claim for New York State is Sojourner Truth, who spent most of her life in other states, but she was born in New York State, about 100 miles north of New York City. Temperance and women's suffrage. What did our local favorite, Susan B. Anthony, do during this time? Well, her first job actually was working for the Daughters of Temperance. And she actually gave her first public speech for the Daughters of Temperance. She and Elizabeth Cady Stanton in 1852 founded the Women's New York State Temperance Society. They had a goal of petitioning the state legislature to pass a law limiting the sale of liquor. And, you know, notice the term limiting and not forbidding it entirely. The state legislature rejected the petition because most of the 28,000 signatures were from women and children. Anthony decided then that she ought to focus on women getting the vote so that politicians would listen to them. She ultimately resigned from the Women's New York State Temperance Society. A lot of you may have read about the Prohibition years, especially in a recent book written in 2011, Last Call by Dr. Okrent. This is a very good book, and it was made into a PBS special with Ken Burns and Lynn Novick. You can get this for free on the PBS website. You know, it contains many clips of prohibition scenes that we're kind of all familiar with from various movies and TV shows. And we get the idea from some of these things that prohibition was an American white male thing. And really it wasn't, because more recent scholarship has explored the role of other countries in prohibition. This book, entitled Smashing the Liquor Machine, gives a global perspective on this and also includes African Americans and Native Americans and women's perspectives as well. So a lot of interesting scholarship lately, and there are on the slide you could see the dates of the amendments regarding prohibition. And William White calls this period a period of demedicalization and collapse of addiction treatment. So the idea was that we were, in the late 1800s, people were very excited about the Association for Treatment of Inebriety and so forth, but this did not last somehow, and when Prohibition came in very strongly in 1919, people, you know, just had an idea of therapeutic pessimism that nothing was going to work very well. So from 1935 to 1970, hope re-emerged. And 1935, of course, was the beginning of the development of Alcoholics Anonymous. And in the early 70s, NIDA, National Institute of Drug Abuse, and NIAAA, National Institute of Alcohol Addiction and Abuse, was created. We focused on the neurobiology of addiction, and we established also treatment standards, and Joint Commission began to regulate treatment of alcohol and drug use, and there were state agencies developed as well. We had improved insurance coverage at times, and the same story is applicable today. From 1970 onward, we also had development of strong organizations, American Society of Addiction Medicine, American Association of Addiction Psychiatry, yep, and ATOD, which is American Association for Treatment of Opioid Dependence. We had the development of addiction medicine fellowships and also addiction psychiatry fellowships. And did I tell you we got ours approved? Yes. And we also had development of medications which were FDA approved for the treatment of substance use disorder. And that was, of course, a very exciting development. We just had more in our treatment armamentarium, and the list of those is on the slide. So, just a little bit about local timeline before I give this to Dr. Mathis to get into the future. The earliest treatment program that I could find, and it's probably incorrect, but Delphi Drug and Alcohol Council, now known as Delphi RISE, began in 1936. Then in 1941, Dr. Kirby Collier, who was a psychiatrist, met with Bill W. Bill W. is one of the founders of Alcoholics Anonymous, and he's referred to as Bill W. He worked with Bill W. to bring Alcoholics Anonymous meetings to Rochester. In Kodak, Dr. John L. Norris was working, and he promoted the AA and disease concept of alcohol use disorder in his work with Kodak employees. And later on, of course, he had Norris Clinic named after him. In 1943, Monroe County Hospital opened a ward for treatment of people with alcohol use disorder. Again, more of the local timeline. We had the National Council on Alcoholism and Drug Dependence begin in 1946. That is still going strong. In 1948, we had Reverend Tom Richards develop the first halfway house for people with alcohol use disorder. And there is a Richards House today named after him that is a part of the VA treatment system. So we also had, in 1949, Dr. Kirby Collier invited Bill W. to speak at an annual APA meeting in Montreal. And that was significant. John L. Norris Addiction Treatment Center opened in the 1960s. And East House began in 1966. It did not admit people with substance use disorder until 1973, but since then it's been part of the landscape of East House. Rochester General Methadone Program opened in '72, and our methadone program opened in 1950. Now we call, 1973. And we are now celebrating our 50th anniversary. And nowadays we call them opioid treatment programs. So 77, Huther Doyle Agency began, 79, Catholic Family Center, 81, Park Ridge Chemical Dependency, including an inpatient rehab at Park Ridge. Now, a lot of people somehow assume that the University of Rochester had a rehab at some point, an inpatient rehab, but they are incorrect. We never did have one. 86, Genesee Alcohol Treatment Center opens. I was their first medical director at that time. And then that was followed by Westfall Associates and the U of R Alcoholism and Drug Dependency Program in 1986. That was later on in 1990 merged with the methadone program and later on also renamed Strong Recovery. St. Joseph's Villa developed a addiction treatment program as well. So, and this is the last one, and it ends with Dr. Mathis, as you can see. We had the Pathways Methadone program develop in the mid-90s, and then we had Syracuse Behavioral Health come in Rochester to provide detox management. Later, this was renamed Helio. Then in 2018, we had JACASA opioid treatment program begin. And that is a methadone provider as well. That is Genesee County. So that's been an important contribution to the local treatment landscape because people don't have to drive so far to obtain their methadone. Our HRSA grant began in 2019, and we've just recently been approved for another 5 years of the HRSA grant. So that's been a very exciting thing to work on. And in 2023, we're up to Dr. Mathis here. The Addiction Psychiatry Fellowship is approved.
Thank you, Dr. Baciewicz, for walking us through that history and for the fellowship to be included on this local timeline. Just to note that it is the first ACGME approved fellowship in addiction training in the region. So whether that's addiction psychiatry or addiction medicine, and we're really honored that our department is a part of making that history for this region. Only the clicker works. Okay. So as a theme in terms of the present and future of strong recovery and addiction psychiatry, we're going to talk about innovative and integrative approaches to clinical care, education, and a quick note on research, which we hope will continue to grow and develop in addiction psychiatry in the future. But before I jump ahead, I do want to acknowledge two important examples from Dr. Baciewicz's tenure of innovative and integrative approaches to addiction treatment. And first is the Norris Clinic Partnership. So Norris is an inpatient substance use disorder treatment program, one of 11 state ATTCs, state qualified or state administrated inpatient addiction treatment programs. And for many, many years in inpatient programs, there was no availability of methadone for patients who were presenting. So if someone is experiencing opioid withdrawal, completes detox, and then wants to continue on for treatment, and they were admitted to an inpatient substance use disorder treatment program, they may be able to receive counseling and group therapy, but they were not able to receive methadone as a medication for opioid use disorder. And this has to do with federal regulations related to how methadone is prescribed and administered for opioid use disorder, including the need to be administered through federally licensed opioid treatment programs. And none of our state ATTCs and inpatient substance use disorder programs were affiliated or connected with an opioid treatment program. Therefore, they could not provide methadone. So you might imagine someone who is trying to stay in an inpatient program for 14 or 28 days, experiencing ongoing opioid withdrawal, which may have been ameliorated by supportive treatments, but then continues to experience cravings and unable to access the gold standard treatment for that disorder until they have been discharged from inpatient. Under Dr. Baciewicz's leadership, we developed the first of its kind partnership with the state organization to provide methadone to patients as they are admitted to an inpatient program. That means individuals with opioid use disorder who are looking to continue on methadone and be enrolled in strong recovery can start methadone with strong recovery, continue to have their dose titrated while they are admitted in Norris Clinic. This does wonders for retention for individuals in inpatient treatment, making sure that they're able to stay the duration of that treatment to receive the additional psychosocial and therapeutic supports, while we're also decreasing gaps in care, decreasing challenges with transitions of care, so that when they are completing their inpatient program, they are already enrolled with us and can continue their treatment. And again, this goes back to being innovative and integrative in our approaches to clinical care and other aspects of addiction treatment. It's really important because the history of addiction treatment, unfortunately, has been so siloed, right? Siloed from medicine, sometimes even siloed within psychiatry. So thinking about ways to bridge those gaps is really important to keep our patients from falling through the cracks. I also want to highlight the importance of co-occurring disorders treatment being integrated in substance use disorder treatment. This is also something that took place during Dr. Baciewicz's tenure. Only 10% of patients with both a mental health and a substance use disorder receive treatment for both. So let's just pause and let that sink in. Right, that 90% of individuals who have both a substance use disorder and a co-occurring psychiatric disorder will not receive treatment for both. They may receive treatment for one or the other. Even then, a lot of those patients, because of those comorbidities, find challenges receiving treatment for one or the other. By establishing co-occurring disorders treatment within strong recovery, we're making sure that we're meeting the needs of the whole person. Because of our history of innovative and integrative approaches to clinical care and to systems level problems, we were really brought into conversations at the level of the hospital system as a whole, but also the county in responding to the overdose crisis. So the HRSA grant was provided to our department in the context of the overdose crisis as additional federal funding and state funding is being made available to help us address this really critical need as overdose deaths continue to rise at a local level, at a national level, really at the highest rates that they've ever been historically. And so how are we providing leadership and support for the hospital system and to our county in addressing this critical area of need? So leadership from Strong Recovery has been involved in the URMC overdose task force, in Monroe County Department of Health task forces, and we're really providing subject matter expertise to inform clinical and system level responses. Pictured here, we have members of Strong Recovery leadership with the New York State Director of OASIS, the Office of Addiction Services and Supports, really as an example of the ways in which we collaborate with local and state leadership to provide expert clinical care to our patients. And in particular, I want to highlight our two co-directors of clinical operations, Itza Morales and Julie Actel. Patrick Setch, who will still claim, for now, even though he's moved on to bigger and better things. Charles Brown, who is a legend in Strong Recovery and our longest tenured counselor who has been working at Strong Recovery for over 30 years. And Kelly Vandermark, who is a clinical coordinator for SUDPC, our Substance Use Disorders in Primary Care. And that program was a specific response to our URMC level task force in terms of addressing the overdose crisis and how we can support our primary care network in safe prescribing of opiates and helping with transitions of care and decreasing care gaps for individuals who have developed an opioid use disorder. So, SUDPC. I really want to highlight this program as another example of an innovative and integrative approach to clinical care. It comprises a mobile team of addiction professionals, which includes peers, as well as CASACs, certified credentialed alcohol and substance abuse counselors. We provide consultation and assessments for patients throughout the UR Medicine health system. So it was initially developed to support the primary care network, right? So our counselors can actually go to primary care offices and meet with patients physically in their doctor's office, rather than coming to our BHC Health campus. For many patients who are first engaging with substance use disorder treatment, all of the stigmas related to that can make it uncomfortable to walk through those doors. So how can we meet them where they are? And this program does just that. But it has been expanded to provide inpatient and outpatient consultation to general medical and surgical teams system-wide. So we've developed partnerships with transplant team and Dr. Nichols with transplant psychiatry to really think about addressing how we can comprehensively address substance use disorder needs for that population. We're working with cardiology and cardiothoracic surgery as we think about endocarditis management and treatment for patients with injection drug use and substance use disorder. So this team has really expanded and is on the front lines of innovative and integrative approaches to addressing substance use disorder for the health system and for the region. SUDPC was established as a part of an expansion grant through the Certified Behavioral Health Clinic, so CCBHC. I borrowed these slides from Patrick with his permission. So why are we highlighting CCBHC? So the whole point of CCBHC is to provide this integrated treatment approach. It is to include mental health and substance use disorder treatment together, so that we're breaking up silos. It is to address primary care needs through the inclusion of a primary care screening and referrals to treatment. And so CCBHC provides flexibility for us to be able to integrate all of these various aspects of a patient's care. So at the core, we are providing crisis services. We are doing screening, assessment, and diagnosis, risk assessment. We have both outpatient mental health and substance use services, but we're also including peer support, family services, psych rehab services. Our outreach team has expanded tremendously as a result of us becoming a CCBHC, which means that we are able to integrate the social determinants of health in a really comprehensive and artful and very strategic way. It has been phenomenal to see the way that our outreach team has been able to meet the needs of our patients and keep patients engaged. Substance use disorder treatment is challenging in some ways and also rewarding. And some of those rewards come when we see that we're able to meet the physical health needs, the psychosocial health needs, as well as the substance use disorder and mental health needs of our patients. I'm not the CCBHC expert. There's so much more I could say here, but what I will say is that this model is a part of what is moving our program forward into the future to be able to continue to provide integrative and innovative clinical care to our patients. Another example of this is the Summits Unit, which is a collaboration between MIPS and Addiction Psychiatry. And led by MIPS and Dr. Harris and his team, the specialized inpatient medical unit provides medical treatment for the medical sequela of substance use disorders, including long-term antibiotic therapy for patients who may need that. We have embedded CASACs and peers on the unit who are providing substance use disorder treatment alongside this medical care. This means that there are groups on the unit that are specifically targeted to address substance use disorder treatment. And For those of us who are working in inpatient psychiatry, you may think, well, of course there are groups on the unit. We're a psychiatry department, but this is unique because it's not a psychiatry unit. It is a medical unit. And for the patients who end up on this unit, if they were in anywhere else in the hospital, they'd be sitting in a very narrow bed with a partner for 6 weeks doing nothing but sitting in a bed with a partner for 6 weeks, right? And so by creating this unit, we're able to create a therapeutic milieu. And again, I'm not the expert on this. You can talk to Dr. Harris, but I want to give their team a shout out and to highlight the collaboration between MIPS and addiction psychiatry that really makes this innovative approach a possibility. And one of our ultimate goals is to facilitate patient engagement in substance use disorder treatment post-discharge to decrease the recidivism for these really high risk and high utilizing patients in our health system. Another great example of integration in our clinical services at Strong Recovery is the integration of a co-occurring pain and infectious disease treatment. And so right now we are able to offer chronic pain consultations for patients with substance use disorders who are currently enrolled in Strong Recovery. Another reason why this is so critical and so important is because when you think about patients with substance use disorder who are engaging with the healthcare system broadly and the challenges that they face, whether it's due to stigma, whether it's due to the chronicity of their health challenges, and so they're more complex by the time they present to care, it creates so many barriers for them to be able to access expert pain management. And if you think about a patient with a substance use disorder history, and if they show up to a pain management clinic, there are so many things that may be perceived as red flags when they land at that door. By providing these pain consultations within our clinic and within our program, we have clinicians who are trained to understand the unique needs of individuals with co-occurring substance use disorders and chronic pain. We recognize that there is a high comorbidity within that population, and we're able to meet with them with non-stigmatizing and expert approaches to managing their pain. We've also included expanded STI screening, and for the first time this year, Strong Recovery is providing hepatitis C treatment, not just screening and not just referrals, but within our clinic, we are providing hepatitis C treatment to patients who are enrolled in Strong Recovery and have hepatitis C. In particular, I want to give a shout out to Dr. Neha Pawar for the chronic pain consultations, and also our medical nurse practitioner, Melinda Godfrey, who has taken the lead in providing Hep C treatment to our patients. Another example of the ways where we want to decrease barriers, where we want to integrate expert treatment into our already long-standing expertise in substance use disorder treatment. And now I'll say a word about innovative and integrative approaches to education. First, I want to give another shout out to Julie Achtel, who is the Director of Counselor Education for KSACS and for Strong Recovery, in her leadership in developing this partnership with the Margaret Warner School of Education, as we are now providing an advanced certificate in addiction counseling through the Warner School. And it is a partnership between our clinic and Warner, where three of the courses are provided by us in addiction psychiatry, and 3 courses are provided by the Warner School of Education. That program has launched just last week. We had our first class on site at Strong Recovery at the BHC in our multi-purpose room, where we are beginning this course of education. It is for master's prepared clinicians who have yet to receive the necessary educational requirements to become a KSAC. And so again, because this is innovative and integrative, we're thinking about folks who may already be working in the mental health field, individuals who already may have a master's degree in social work or a master's degree in counseling and looking to become an LMHC or some other certified counselor, but still have not had the core education to address substance use disorders. We're going to provide that so that they are prepared to do both. And I believe we have members of our department who are participating in that program this year, which is very exciting. And as has already been mentioned, there is the Addiction Psychiatry Fellowship, which we are also very excited about, and actively recruiting fellow for the July 24 academic year. We have both addiction psychiatry and addiction medicine boarded faculty. We have a very diverse training backgrounds. And again, I think it speaks to the strength of our department as a whole in terms of our really unique place within psychiatry, where we have strengths in med psych, strengths in consultation liaison, strengths in collaborative care and wellness. And addiction psychiatry is building on those strengths. So our training backgrounds include general adult and child and adolescent psychiatrists, family medicine physicians, pain medicine, med psych physicians, and toxicologists. We also will be training within the setting of a wonderful multidisciplinary team. That wonderful team is the Strong Recovery team that you all have heard so much about. But they include medical and psychiatric nurse practitioners, addiction counselors, mental health therapists, family specialists, psych, rehab, and vocational therapists, case management, certified peer specialists as well. And our clinical experiences will be varied. I think we'll be hard pressed to find another addiction psychiatry fellowship that can provide the breadth and depth of clinical experience that you will find here at Rochester. It will include inpatient and outpatient substance use disorder treatment, inpatient and outpatient consultation to medical and surgical teams, adolescent and young adult services, pain and addiction, Sobriedad Fuerte for Spanish-speaking patients, again, substance use disorders in primary care, as well as providing psychiatric assessments for the Department of Corrections, which we also provide at Strong Recovery. So again, our fellows will be well prepared with a breadth of clinical knowledge and experience to address the needs of this community in this current era of addiction treatment. We hope to also continue to collaborate throughout the department as we're thinking about addiction education, not just within Strong Recovery, but more broadly speaking, including revising our resident addiction psychiatry didactics, collaborating across subspecialties, really all of our subspecialties, consultation and liaison, geriatrics, forensics, child and adolescent. Substance use shows up everywhere. And we want to make sure that the expertise that is provided through addiction psychiatry can be well integrated into all of those clinical settings. We also have an addiction psychiatry medical student elective that is available by request. And we continue to provide clinical and educational opportunities for learners in other training programs. This past year, we have had marriage and family therapy trainees as interns in our program. We have a doctoral student. We hope to expand opportunities for psychology trainees as we're continuing to work to recruit higher level addiction psychiatry researchers to our department. And my brief word on research is just to acknowledge the research that is already happening, the current research and grant activities already happening that are addressing substance use disorders by the faculty listed here, and to make the note that we are continuing an ongoing recruitment efforts for a researcher in substance use disorder with a strong consideration of how that research will be integrated into our robust clinical services. As I wrap up, I want to say, as we've already said, that the work that has been done is being done because of the wonderful team that we have. Strong Recovery's team has expanded tremendously over the years as our population and patients has expanded over the years. Currently, we have over 80 faculty and staff who comprise the Strong Recovery team, and we're incredibly proud of the work that they do every day. Hi to everyone on Zoom. And so I just want to say thank you to our Strong Recovery team. Thank you for your dedication to this patient population. Thank you for the hard work that you put in every day when we're working with very, very complex and challenging patients. And the complexity and the challenge has only grown in recent years as we're seeing across all areas of psychiatry, both from a mental health crisis through COVID and post-COVID, the overdose crisis through COVID and post-COVID. we're all working really hard, but we really do come together as a team to think about how we can be innovative and creative in addressing the needs of our patients and supporting one another. So here's some more staff photos because I didn't want anyone to be missed. Make sure that you can find yourself somewhere in these pictures. But again, thank you to all of you for making Strong Recovery what it is. Thanks to all of you for these 50 years of excellence in service and dedication to this patient population. And we want to invite the whole department to come and celebrate with us as we celebrate our 50th anniversary. This Friday, we will have our second annual Health and Wellness Fair as a part of our 50th anniversary celebration. There's going to be music. There's going to be games. There will be over 30 vendors from local community agencies on site. There will be food and drinks and giveaways, all happening in the Behavioral Health Campus parking lot. So come on out and celebrate with us. 50 years is a big deal, and I'm really happy and excited to be a part of this team to mark this occasion. Thanks.
Just want to recognize our two presenters. Just a wonderful job in describing what could take hours here and all the staff that make this happen. In terms of both clinical, educational, and research, the spectrum of service is unbelievable. The programmatic breadth and development that you've done, all of you that are being part of it, and taking things to Warner School and so forth, has really just set a model, I think, for the rest of us to follow. So kudos to all of you for great work. We've got some time now for any thoughts, questions, and I just want to remind people online on Zoom to submit their questions in the chat feature. Please.
Hello, thank you very much for this presentation. Big fan of Strong Recovery all the way around. My question, I guess it's kind of broad, but bear with me. How would you describe how the philosophy of Strong Recovery has shifted with the harm reduction movement? Great stuff, pain points, all the way around.
Well, I think this is very evident if you've spent any amount of time in the field. And I remember when I first started, I first started in this field in 1986 at Genesee Alcohol Treatment Center, and people were discharged for, say, one very minor relapse. Things have undergone quite a sea change since then in every local program, I believe, and including ours. And I think we've benefited from harm reduction initiatives, especially giving out naloxone kits. Very important.
So I think this is an evolving process, and it's evolving both in terms of how that is being embraced at state and federal levels, and then also how we implement that at a local level. And one thing that we're mindful of is to really balance the strengths of what our program has done well and thoughtful integration of some of the sort of changes and evolution in the field. And I think our leadership team is really thoughtful in thinking about how to balance those two things. For those in the room who may not be aware, the biggest change is moving from an abstinence-only model, so to speak, to a harm reduction model where we are working with patients and thinking about how to reduce harms related to their substance use up to and including complete abstinence from substances. But there is a lot of variability in what that means for individual patients and even individual programs. And so we're working with our team to define what that means for Strong Recovery.
Thank you. Gloria mentioned the name Kirby Collier. And I think most people know that Collier Lecture is the most prestigious lectureship that our department has, and we do it every year, and that is actually endowed by Kirby Collier, who founded Alcoholics Anonymous in Rochester in 1941. And so, the tradition of the addiction psychiatry runs very deep in our department, and hopefully this year is the year that we transform our strong recovery program to the division level.
Great presentation. So I think there's a lot of innovative things, right, that have happened and continue and will continue to happen in strong recovery. But I think one of the key ones is the role that strong recovery and addiction psychiatry can play in developing more addiction psychiatrists in our region. Now, I can't think of a better place for someone to do a fellowship than strong recovery. And now that we have this program, what can the rest of the department do to help you attract fellows to this program?
Great question. I'm so glad you asked. So first is let people know that we exist. Let people know that this is something that our department has. We finally have a presence online. I invite you to visit the Addiction Psychiatry Fellowship website as a part of the GME programs on the department website. As we're approaching interview season for the residency, that means when folks are looking for places to interview, they can see that our residency is also supported by, our fellowship is supported by the residency, and that this is a place where they can receive addiction psychiatry training. So tell people we exist. If there are folks who express even a slight interest in addiction, send them my way. Please copy me in on those emails. I am always happy to receive those, whether it's medical students, residents. I enjoy talking with them about their interests and their passions, and seeing how we can support that in addiction psychiatry. So spread the word.
We have a couple questions from our online folks on Zoom. First, Dr. Oliveras asks, can either of you define the difference between addiction psychiatry and addiction medicine, as the lines between the two tend to be blurred?
Oh, okay. So addiction medicine is available to, it's basically who's eligible to take the exam or to do a fellowship. And for addiction medicine, you can be any kind of physician other than a DO. The DOs have not yet resolved certain problems about this. They get to be a little bit thorny, these problems. So, but anybody can take it. Tim Wiegand, for example, a lot of you know him. He is certified in addiction medicine. Steve Novak in our program is a family medicine doctor, and he is certified in addiction medicine. And we have many people who have gotten that certification. And addiction psychiatry, you have to be a psychiatrist first.
And I would say that I actually think that the lines are blurred between the two when it comes to clinical practice. I think some of that is intentional. Certainly a psychiatrist is a psychiatrist. And so when you're thinking about management of co-occurring psychiatric disorders, then that is the strength of an addiction psychiatrist. When you think about the management of co-occurring medical conditions, then it may be the strength of someone who has received more significant general medical education and then an addiction medicine fellowship. However, I would say that management of a lot of the co-occurring medical conditions is also done by individuals who receive addiction psychiatry training. So in practice, the lines tend to be blurred, I think, somewhat intentionally, largely because we just need more people who are trained in treating addiction from a physician perspective. The workforce need is growing. some think that there is a major philosophical difference between the two, including the embracing of harm reduction happening more from an addiction medicine perspective. If you do think about the comorbid medical conditions related to addiction, certainly a harm reduction model makes a lot of sense, because we're trying to decrease rates of infection and things like that. A person may not be completely abstinent to decrease their risk of some of the serious medical comorbidities. But that being said, addiction psychiatrists also embrace that model for the very same reason. So I probably am not the best spokesperson to say what's the difference between the two, because I do think that we're sharing a lot with each other. At the end of the day, though, psychiatrists treat co-occurring psychiatric disorders.
We have one more question online, and then we'll ask our audience live. Dr. Robert Goldstein asks, how has this remarkable program development influenced patient outcomes?
Great question. We're still working on how we can best track our data to back up some of the statements that I'm going to make. But here are some of the statements that I'm going to make. One of the ways is really by eliminating barriers to care. So first, Strong Recovery's opioid treatment program, specifically for receiving methadone, we do not have a wait list. Patients call us and say they want to receive methadone, and we are getting them an intake within a week. I think that's just one example, right? So when it comes to access to medications for opioid use disorder, we are very innovative in how we approach that. If a patient is wanting Suboxone or buprenorphine naloxone products for treatment of opioid use disorder, we have a rapid access clinic that operates 2 days out of the week. And within a week, we can get that patient in to receive that medication. So really what we're hoping to do is decrease barriers to engage patients early and often and continually along the course of their recovery. And a lot of the programs that we've developed in an innovative way really speak to that, from our collaboration with the Summits Unit, which is part of that same mindset where we're getting to folks early and often and connecting them to our outpatient program as quickly as possible, whether it's our partnership with Norris. So I don't have all the numbers just yet, but I'm going to say we're decreasing barriers and we're getting people into care faster.
I also just want to add to that, non-scientifically, but definitely seat of the pants, driving into BHC, community division area, last year, post-COVID, during COVID, the innovation of this program of Strong Recovery, serving individuals, whether it be in the parking lot, developing things with security, providing services where you couldn't imagine what happened years before that, really, I think, speaks to both the breadth of your services, but the innovation and the thoughtfulness of it. You're going to do what it takes, and that's really the difference, I think, that makes you stand out, I think, as a national, if not international model. So looking at the time here, we're just about at the hour. I just want to remind people there's a QR code if you're online to provide your Grand Round survey and get CE credits for those who wish. I want to thank our presenters, Dr. Gloria Baciewicz, Dr. Myra Mathis, and all of you at Strong Recovery who have made this possible and continue to make it, again, a model program, I think, nationally, if not internationally. Thank all of you, and thanks everyone for attending both online and in person.